All right. Well, thank you everybody that's joined on already, and to those of you that are hopping on as we speak. We are really excited to share this webinar series with you guys, and I want to start off by giving a heartfelt thank you to Endo Pharmaceutical. So Endo really made this possible by sponsoring not only the webinars, but some of the benefits that come from you attending the webinar. And we're going to start off. The first one, as you know, is tips and pearls for office procedures for APPs, and that's tips and pearls for not only office procedures, but also for coding. And we've got a fantastic panel for you guys today. And as you're hopefully well aware, there are several benefits of joining tonight. One is that you're going to get three really good talks that I hope each of you find intriguing and really helps your practice. But in addition, because of Endo's gracious support, you are each going to get a 1-year complimentary affiliate membership to the AHS. And you have free access to this webinar series of 3 lectures. And there are a lot of membership benefits to being an AHS. And you'll find out more about that when you complete your journey with this. And it also gives you a really nice discount on the annual meeting if you're planning to attend this year. And it includes free partner, guest, or child registration. We do have 2 more in this lecture series. One coming up will be on October 15th, where this is the group we have coming. This is going to be a great talk called Snakes in the Grass, Avoiding Misdiagnosis of Common Hand Conditions and Missing Rare Hand Conditions. And you can see an outstanding faculty there with what looks like teenager Mark Richard, and then Jen Walgie as well. So that's going to be on October 15th. And then on November 12th, if you want to put it on your schedule, we will have a endo lecture as well about using XIAFLEX in your practice. And for those of you that haven't signed up, I would strongly encourage you. One great thing about AHS, in addition to wonderful benefits, is the meeting is always at incredible places, and this year is no exception. It's going to be in Hawaii, January 14th to 18th. It'll be on the Big Island in Hawaii, so don't miss out on that opportunity to join. And for tonight, we've got a great lineup. I called it, you get a little bit of everything. You get a PA's perspective. You're going to get perspective from Dr. Garcia as a plastic surgeon and orthopedic surgeon. And so I put you're going to get plastics, ortho, PAs, and bow ties. Unfortunately, Jerome didn't don the bow tie to round it out. But looking forward to tonight. And we're going to begin with Jerome's going to give us the opening talk. And then we're going to have the 3 lectures. If you have questions along the way, please enter them in the chat. And between lectures, we'll have time to field a few of the questions. And then at the end, we'll have plenty of time to get to all of your questions. So again, I encourage you to put all your questions in the chat. If you don't mind, please mute your mics. And Jerome, I'll let you take it away.
Sir, thank you very much. Want to thank everybody for taking the time to join us. Really excited about this webinar series and the incredible support from Endo for putting this together. Can you guys see my screen?
Yep.
Okay. So my name is Jerome Wenninger. I'm a physician assistant. I've been a PA since 2001. I've been in orthopedics since 2009 after finishing my fellowship with the United States Army. Been in hand since 2013. I've had a few different roles in that, and I'm currently honored to be the affiliate director for APPs on the board of directors for AHS and part of this incredible association. I don't have any financial conflicts with this, and wanted to take a little bit of a different approach on perspective from the APP and how they function to help with efficiency, and looking forward to getting more patients taken care of and being part of the team. For anything that we do, experience has prepared you for your practice. One of my mentors said that you are a product of your experience. And so everything that we do and how we do it is looking for our experiences to guide us in how we do our practice. Early on in initial training, whether that's your initial training as a provider or any type of fellowship, during that training, the resources are provided. You have mentors, you have teachers, you have resources. One of the things that I was taught as part of that process is every student is an investment by that program to make sure that you learn the standards of care, that you're a provider that's going to be able to provide those things. Once you complete that training, you then move on. For me, that movement was during officer basic course during 9/11, which as of tomorrow was 13 years ago. I left officer basic course and went to my first practice. And in the course of the first 3 years, I was deployed. I had medics with little to no experience with basic skills. We were in austere environments. We had people rotating in and out. We obviously had hazards. We had varying level of care from sick call to basic musculoskeletal complaints to obviously battlefield trauma. And this caused me to have to focus on building my team and how we were going to do things, standardizing things. As I went through that process, I then went to Fort Bragg and then again went to Afghanistan by myself, where I inherited an aid station with medics I'd never met. And again, went through that process of learning people, setting up our aid stations, preparing from everything from a basic evaluation to trauma. Those skills then were utilized by the military for me to work with team building, focusing on National Guard and Reserve units as they were preparing for deployment. This meant integration of Reserve and Guard providers, then integrating them with various nations in theater, taking all those different skills, helping them utilize those skills, taking all the different backgrounds, whether it was European, South American, or US providers with their different backgrounds, having them come together and using their expectations and their experience to be able to build those teams, obviously with the same goals of providing care. And all of these experiences, all of these processes helped me learn to develop these things, which were critical as I then transitioned into private practice. Whether it's an orthopedic clinic or a plastic clinic, there was different resources. In my mind, going to out of the military into civilian practice, it was going to be the kind of the same standard approach. But as much as things change, they remain the same. When I was in private practice, we had radiology techs providing assistance, casting, helping with clinics. When I was in the federal system with the VA, we only had nurses. In hospital systems, I had nurses and MAs and CAS techs, and then another one where we had no nurses and just MA and CAS techs. All these varying resources made it difficult to be able to use one standard approach. And so one of the things that I focused on was, how do we build teams? How are we going to go through these processes in doing these things? And so as that process went through, one of the things that I put foremost in my mind was the surgeon is the coach. And for football analogy, for those familiar with football, the surgeon's the coach who's directing the play, calling the plays, making sure that there's identification of what things need to be taken care of, how we're going to do those things clinically, what's going to be thresholds for patients, what are they going to do. And so as the surgeon functions as a coach, calling the plays, determining the patient population, how we're going to take care of them, the APP is going to function as a QP, running those plays, ensuring everyone knows their roles, communicating. And I think that's one of the most important things, ensuring there's good communication between all the different aspects, whether that's in the operating room, minor procedure room, and clinic, making sure that staff administration understand requirements, upcoming delays, potentially time off, how those patients are going to be cared for as you go through there. In addition, as a QB, you're always seeking improvement. This lecture series, coding, procedures, medical knowledge, personal growth. Obviously, everybody's focused on making sure that they're providing the best care that they can, but also personally growing and reinvesting into their lives and their mental health in this process. Providing feedback on what things were struggles, what things were great, and then re-looking at how you can approach those things to make them better. And then one of the biggest things is investing in one another. And this is one of those parts that helps build that team. And then what you do is you set up the standards in the instruction. Whenever I get a new assistant in our clinic, whether that's a CAS tech, an MA, sit down with them and just talk to them about what we are expecting to do, what I expect the standard of care, what things I need to do. And we've set up systems. Another great mentor of mine, a leader in the United States Army, told me that systems endure, people come and go. You can have a charismatic leader, but if you don't have a great system, the entire structure will fall apart if that charismatic leader isn't there. And so systems are part of the process. How do you identify patients? How do you go about the education process? How do you go about your procedures, making sure that you're meeting all the requirements as part of that procedure, doing patient education on risk benefits and alternatives to treatments, making sure that they understand what they need to do and where they're going. One of the things that I've really focused on is identifying areas of concentration. In my clinic, splinting, casting, reductions, injections, and procedures are an everyday situation. And so they need to understand what it is that I need them to do, what things are going to be needed for this injection so that I can continue seeing patients come back to do the injection. And it's a seamless process where you come in, talk about what you need to do, complete the injection, make sure that they understand what's going on and be able to move on. Or if there's a procedure, understanding who needs to be there to potentially help, what situations require procedures, and then what those setups are. And lastly, empowering your team, helping them understand that they are part of the team, giving them a voice as part of the team. If they are having those issues, making sure that they're able to voice their concerns or their questions, and then just educating them to what you're doing and why you're doing it. As I've gone through this process in my time as a PA, I've had medics, cast techs, and MAs. 2 of them have become doctors, 11 have become PAs, 2 have become nurse practitioners, and 30 have become nurses. Most of the people we work with, they're not at the pinnacle of their career. They're looking to advance themselves and grow. And so part of this process is investing in them, ensuring that you build them and develop them, bringing all of the things that they want to the table, allowing them to learn, feel comfortable in what they're doing, and then continuing to feed them that information and growth. It is easily the single most important and rewarding part of team building. Seeing someone move up and advance their career is just one of those things that I've always been very satisfied and happy with. And then support and grow each other. I think one of the biggest things, whether it's the surgeon or yourself, everybody just needs to know that we're on the same sheet of music, that we're all working together, and that we're doing great things. Whether that's a tough case where you come out and go, that was a really good case. You really handled that really well. We did great. Even just getting some information from your surgeon where they were like, that was good anticipation. That's what I need you to do. Thank you for reminding me about that. You know, I knew we were going that direction, but that helped in that process. And so this is part of the process of looking for efficiency in your daily routine as you complete procedures, as you see patients, do injections, go about taking care of your patients and making sure you're efficient and not always running behind. At AHS, we've used these things. AHS is an extremely APP-friendly association. There's currently specific webinars, classes, and socials geared towards APPs. They have an affiliate position on the board for APPs that will be turning over this year. They have APP classes at the annual meeting. For the meeting in 2025 in Kona, we have a 2-hour APP program that will be run by Carrie. We have a casting and splinting program that will integrate not only APPs, but also the ROT counterparts so that you have experience with both those situations. We have an injection course that's going to be sponsored by Endo. And then we're going to have an APP social where everybody gets together, gets to know each other, and we continue to grow as a family in the process. So this is the first part of this webinar series. Thank you for your time. I'm going to hand it back off. Actually.
Thanks, Jerome. Yeah, you can. There we go. And then Ryan, if you want to hop in. And Dr. Garcia is going to give the next talk on procedures that you can do in the office and some pearls on that. Ryan, I think you're on mute.
I got it. I think I got it now, right? Everyone can hear me. Perfect. So thank you very much for the introduction. I basically put this talk together to kind of introduce folks who are not quite as familiar with a technique of in-office procedures called Volant. So we'll start there, a little bit of education in that, and then I'll end it with how the APP can be a vital asset to the flow of this. Okay. No relevant disclosures for this talk. So what's the big deal when it comes to the use of epinephrine with local in the hand, the so-called volant technique? Well, we've been using local in the hand for many, many, many years, decades, if you will. It's the use of the epinephrine that really changed things, and it's the way in which you can use epinephrine in order to avoid the use of a tourniquet. And even in my orthopedic training almost 20 years ago now, it was absolutely forbidden. Even in some of these older textbooks, you can find that that authors have recommended against the use of epinephrine in the hand and fingers. Plastic surgery, being that I also did a plastic surgery residency, we were very, very familiar with doing in-office procedures, much more so than in orthopedic practices, and that's where this really took off. So if you give a talk on Lalonde, I think you have to pay credit to this man right here, Don Lalonde. So chief of plastic surgery, actually, I believe he just recently retired. Really highlighted the way in which to do this safely in office procedures, and he's done it multiple papers and done it in a very scientific way. So you may ask yourself, well, is it safe to use epinephrine in the hand and fingers? Well, this is a series, multiple sites where they looked at over 3,000 patients whom had low dose epi, which we'll call 1 to 100,000 of injections in the hand and fingers, and they showed no incidences of finger ischemia and no cases in which phentolamine was used. So you say to yourself, well, how much volume? And the answer is, well, it depends on the location of the hand. You say, well, what's the concentration? I think most of us are going to be using 1 to 100,000. How about additives? Bicarb will help with the acidic nature of the injection, can be less painful. So how much, we'll get to that as well. And then phentolamine, I'll give you some arguments that maybe you don't really need this. And if you do want to have it in the office, I can show you what we use in our office. So this is basically our setup or my setup that I use, and certainly a lot of my partners do as well. So lidocaine 1 to 100,000, 1%, 1 to 100,000. And you can see a 10 cc syringe. If you fill it up to the 10 cc mark, there's always a little extra room. That's what I use for the bicarbonate. So it's 1 to 10 is the volume of the bicarbonate or the concentration. And it's typically recommended to use the smallest gauge needle. You can try a 30 gauge needle, although you may get CMCR arthritis from trying that, but I typically use somewhere between a 25 and a 27 gauge needle. I briefly mentioned before how much volume can you use? Well, it really depends, and this is from Don Lalonde's one of his papers in his textbook. It really depends on where in the hand you're injecting it. So, for instance, if you look at this diagram, you can easily give 5 cc's at each of the orange dot in the palm or on the dorsal side of the hand, 2 cc's where he shows the blue and red dots, and then limit it to 1 cc at the most distal sites. We talked briefly about bicarbonate and in a 1 to 10 ratio. Don Lalonde recommends doing a very slow injection for his carpal tunnels. He says it takes him 2 to 3 minutes. Tried to do that myself, but I just don't have the patience. And then wait time is really important. We're going to show a study that he did on that. Here is something I think if you're going to compound your own Lido with epi, we did have shortages of Lido with epi, but there was plenty of lidocaine plain. So you can actually make your own, but you got to do it in a very careful way and make sure that if an APP or staff from your office is doing this, that they know what they're doing. So you can take 1 ampule of epinephrine, which is 1 milligram per ml, which is basically a concentration of 1 to 1,000. So any 10 cc syringe, you add 0.1, 50 ml bottle, for instance, you add 0.5 cc's, or you can mix 2 50 cc bottles and use the entirety of the ampule to get you the 1 to 100,000. Here's the study for the wait time importance out of the PRS. Essentially, Don Lalonde looked at healthy volunteers they injected into the shoulder region, and then looked at their relative hemoglobin concentration, and found that the wait time, the best perfect wait time where you get the maximal concentration or maximal efficacy of the epinephrine is right at 25 minutes. So I typically implement this in my practice and bring patients in prior to the procedure, inject them, and certainly wait. How about phentolamine? So this is the dreaded complication. This was published in Journal of Hand Surgery, not Don Lalonde's patient, but he felt it was necessary to put his name on the paper because he's a proponent of doing Lalonde. So essentially, a 63-year-old female who had multiple trigger digits performed and unfortunately had the dreaded complication of digital ischemia. No phentolamine was used, ended up with a couple of tip amputations. It was thought that this may have been secondary to getting into the flexor tendon sheath and too much volume that was sent to the distal tip of the finger. And so just be careful of that. So some would argue, well, maybe you should have phentolamine in the office. Phentolamine is an epinephrine reversal. Literature, I would say, doesn't necessarily support its use. It is extremely expensive in this formulary. And then the questions of, well, how do you do it? What dose do you use? And how quickly is it effective? Well, to answer those questions, Don Lalonde did this study, 22 volunteers, plastic surgeons, residents, a therapist, and a nurse, basically injected both hands in the ring finger with 1% or 2% lidocaine with epinephrine. And an hour later, one hand got saline and the other hand got injected with phentolamine. And here was the result. So time to reversal, which he deemed return of skin color to the normal adjacent digit, about 85 minutes. So about an hour versus 300 minutes with saline. And then time to normal sensation return was 120 minutes or 2 hours after phentolamine was used versus over 500 minutes, almost 10 hours for the saline group. And I use this result actually when patients ask me how long will they be numb. I tell them about 10 hours based on this study. Here's what we have in our office. It is a off-label use. I'll say that again. It is an off-label use of a dental version called Oroverse. It's extremely inexpensive. $100 will get you 10 vials. I use 2 of them at a time. So you get 2 vials and you inject exactly as you did with the Lido with Epi, in same exact location. I found that when I've had to use it, mostly it was for my own peace of mind rather than I really felt that the patient would get digital ischemia. It actually works pretty quick. I think full return of color of the skin might be that 85-minute mark, but you'll see results of this within 15 or 20 minutes. So here's the part for the APP. I think in order to get this up and running in your office, you have to have some dedication to it. And I think each of the providers needs to have some graduated level of comfort. So here's what ours looks like. It's nothing really fancy. You need some durable equipment like a gurney, overhead light, side table storage. But it doesn't have to be expensive. These can be purchased, at a bargain. A lot of this equipment you can actually get used. Some surgery centers sometimes close, or they want to change out the headlamp. I think that's how we got ours, are relatively inexpensive. So it doesn't have to be expensive. The equipment needs. So we have probably too large of hand trays, but I have built a Wallant office-based procedure room in one of our satellite offices. And this is all that the hand trays really have. And so I think you can do most things with it, most of the common procedures that we're doing. You'll need various sutures. We've kind of trimmed this down as well. But to your liking, towels and drapes are plus minus, and then some dressings. So here's kind of what the room looks like. But when you add all the drapes and the hand tray, it actually looks like a little mini OR, and we'll drape off the patient so that they can't see what we're doing. I think for the staff, I think it helps to have sort of a dedicated staff member versus a medical assistant. This certainly could be an APP. They help with room setup, patient prep, room cleaning, turnover, equipment sterilization. I think there's a buy-in process. I think oftentimes they find this new, exciting. Many of them like to be a part of surgery. They don't want to just see clinic all the time. It gives a new form of engagement for patient care, patient interaction throughout the procedure, and it can be a very valuable experience. For physicians looking to get started with this, I always recommend start simple. So if you're worried about using epinephrine in the hand and fingers, do a trigger thumb first before trigger fingers. All dorsal hand procedures are fair game. Simple mass excisions. If you want to do tendon repair, start with a simple EDC tendon repair. If you're going to do Dupuytren, start with a easy pretendinous cord. And then if you're getting started with the carpal tunnels, start out with the elderly and atrophic skinned patient. A lot of advantages to Volant. Again, the APPs can be a vital role in getting this started in an office, can help move things along. Volant has a lot of advantages, reduced cost to healthcare system, and certainly patients with large deductibles. You no longer need you no longer have to wait for a waiting room at the end of a day. There's significantly reduced paperwork involved. NPO status is no longer a problem. Patients can drive themselves home, and we've fortunately been able to negotiate significant increase in physician reimbursement for cases done in the office because we don't have a surgery center fee for it. So in my opinion, I think future hand surgery is Volant, and certainly APPs can be highly involved in this if they desire. So thank you very much. I'll unshare my screen now.
Thanks, Ryan. And Don, thanks for chiming in. I don't know if you could see that, Ryan. Lalonde chimed in on some chat pearls for us as well, that are in the chat for everybody. So great talk. And then Noah's going to bring us home with what's probably the bigger challenge that most of us probably feel like we know the least about, which is coding pearls. And I think this has a lot of real relevance for every one of us. So he'll bring us home, and then go ahead and enter any questions you have in the chat, and we can address those after Noah's talk.
Hi, everybody. Okay, I hope everyone can see the monitor. So my name's Noah Raisman. In my practice of 170 orthopedic surgeons and numerous APPs, I'm the chair of coding compliance, and I also represent hand surgery to the RUC and to the Orthopedic Academy. So this will be a primer. Before we really get involved, I think one of the things that's always important for an APP to be aware of is really what's your value to the practice. We're going to talk a little bit about how APPs bill for their services, but you also want to take into account the things that you don't get paid for, because there are a lot of procedures you're going to end up assisting with that don't pay for an assistant. And every time you see a post-op patient in a global period, you're not going to get paid for that work, but it's a work that you save everyone else in the practice. So I think that you have to have a more global sense of how you fit into the practice. And really Jerome's talk about how to really be part of a team, I think is very critical, because hand surgeons are at a little bit of a disadvantage because so many of our bread and butter procedures don't pay for an assistant. So first of all, everyone should know that there are essential 3 types of billing for an APP. Now, also to note, this is going to depend a little bit on the state in which you practice, because they're going to have very specific scope of practice regulations for APPs. And so third-party payers may also have rules that differ, but these are the basic rules for Medicare. You can direct bill, which means you are using your NPI number and billing without any physician requirement for oversight or co-signature, and that reimbursement will be allotted directly to you. That gets you 85% of the allowable reimbursement for Medicare. If you are in an office setting and are not part of a hospital-associated clinic, you can bill what's called incident to. So that means that a PA or an NP can independently see the patient, but they are activating or being the agents of a plan of care that is set in motion by an MD. So an MD must be on the premises. There must be an established plan of care, which means you cannot bill a new patient incident to, only established patients. The ND does not need to cosign, but it is recommended just to document that you're actioning a pre-existing plan of care, and that is reimbursed to you 100%. In facility settings, you are typically doing what's called split shared visits. So if you are seeing patients alongside a physician, whoever completes a substantive portion, either by medical decision-making criteria or strictly by time, does a documentation and does the billing. And again, physicians are going to be paid 100% of the allowable, and APPs are going to be reimbursed 85%. Now, if you're going to be an assistant at surgery, you're always going to bill using your own NPI number. You're going to bill the same CPT codes as the surgeon you assisted. You have to add an AS modifier, which identifies you as an APP, and then you use one of the two modifiers for assistant surgeon. Only surgeries that qualify for assistance can be reimbursed. And you can find out the list of this through looking at the data file for CMS, which is a Center for Medicare and Medicaid Services physician fee schedule. You may require the surgeon to note that an assistant was necessary. And I think this is critical to make sure that the surgeons working with you are documenting that an assistant was necessary, because otherwise a number of third-party payers are going to reflexively deny the assistant. There are a number of surgeries in hand, wrist, and elbow, as well as plastic surgery, where the designation in the physician fee schedule is an assistant may be necessary, but isn't always necessary. And those are the ones where it's really critical that your surgeon is documenting. Also, as you probably know, if there is a resident available, even if you scrub the case, the PA or NP or surgical assist does not get any reimbursement. And so if you're at a facility where residents are populating the cases, you need to make sure the surgeon notes that a resident was not available during the case. Reimbursement for an assistant surgeon is 16% of the base surgery. And since reimbursement for a PA or NP is 85% of that, 85% of 16% is 13.6%. So that's what you get paid as a surgical assist. Now, when you get to the bulk of what most APPs are going to be doing, it's evaluation and management coding. And this is really focused on the office, but honestly, it's the same if you're seeing consults on the hospital floor or consults in the emergency room. It's all about documentation. At the end of the day, what you need to realize is that the people looking at your documentation don't have a medical background. And now that all of the evaluation management criteria for selecting a code are based on medical decision-making, you need to make it easy for them, because that's what will make your notes unimpeachable. That's what will protect you from audits. That's what will maximize your appropriate reimbursement. How do you do that? You need to read the CPT book and look at the language and use wording, evaluate templates in your various EMR systems. Find things that work for you that reflect the appropriate CPT language. Now, there really are no situations where you can reflexively code level 4 and level 5 on everyone. Overcoding is fraud. So you need to really understand what you need to document effectively in an office note to reach the appropriate code level. Now, the new patient and established patient office codes, you should know, these are the 99202 through 5, which are new patients, 99212 through 5. That last digit corresponds to the level of intensity, straightforward, low, medium, and high levels of risk and complexity. Now, before we go into the details of E&M coding, need to talk for a moment about preoperative visits. Now, it used to be a strategy to hire a nurse practitioner or PA after the decision for surgery is made to go and do a preoperative H&P the day before or a couple of days before the actual surgery and bill for that as an office visit. All of your third-party payers are wise to that, and those are routinely denied at this point. So CPT defines the global period beginning one day before a major surgery. However, CMS defines a global period beginning once a decision for surgery has been made. Private payers are going to follow suit of whatever is easiest and cheapest for them. So they are going to follow CMS's guidelines. So if you have a major surgery coming up and you're doing an H&P or preoperative visit, no matter what you're doing, once a decision for surgery has been made and documented, you're going to get that kicked out because they're included in the global period and basically not reimbursable. Now, a preoperative risk stratification may be separately reimbursable, but that's not typically what we're doing. Okay, that's usually sent out to internal medicine or cardiology or pulmonology. Now, this is a technical point. It may be possible that you can make a provisional decision for surgery pending preoperative risk assessment, consults, and labs, and a final decision for surgery is not being made until that preoperative visit. But that is murky territory. We have no guidance specifically from CMS or CPT, AAOS, ASSH, AAHS. We don't have any guidance as to whether that's really kosher. I think that's kind of sketchy. So I think be conservative because that's how you'll stay out of trouble. And preoperative visits are just generally not reimbursable. All right. So talking about medical decision-making, there are three components: the number of problems addressed or complexity of the potential treatment options, the amount of information processed, and then the potential associated risk of the condition or treatment. Okay, we'll call it category 1, 2, 3. In most cases, the amount of information you're processing is not going to be enough to get you to level 4 or level 5 in that second column. So we're going to be mostly focused on column 1 and 3. You need to meet 2 out of the 3 to establish your code level. So this is a screenshot from the CPT handbook. If we look at a level 3 visit, okay, 99203 for new patients, 99213 for established patients, low complexity is a level 3 visit. That means there's a low risk of morbidity from additional diagnostic testing or treatment. That could be sending people for X-rays, MRIs, lab tests. It could be sending people for physical therapy, the use of over-the-counter medications. That's all low risk. What types of problems are in here? 2 or more self-limited or minor problems, 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Now, here's the stuff in category 2, the amount of data. You can look this over, but you're reviewing external notes, not your own notes, reviewing tests, ordering tests, and using an independent historian. Those of you who are seeing pediatric patients, the parent qualifies as an independent historian. So some of these definitions are unclear. So what's a self-limited or minor problem? It's something that runs a definite and prescribed course, is transient in nature, and not likely to permanently alter health status. A minor sprain or strain would be here. Usually these are not things you would present to a hand surgeon for. an acute uncomplicated injury they're describing as cystitis, allergic rhinitis, or a simple sprain. Again, these are minor problems. Full recovery without functional impairment is expected, or something that's normally self-limited like a bad cold, but it's not resolving. So if we look at the next set, this is what gets you to a level 4. Chronic illness with exacerbation, progression, or side effects of treatment. That's one that's worsening, poorly controlled, or progression requiring additional care. It also means anything that's not at treatment goal. If you're not at your treatment goal, that is exacerbation or progression. An undiagnosed new problem with an uncertain prognosis is something you can use to get you to that moderate category or level 4. It represents a condition likely to result in a high risk of morbidity without treatment. And we'll come back to that idea. An acute complicated injury is defined as an injury which requires treatment that either includes evaluation of body systems not directly part of the injured organ, or it's extensive, or the treatment options are associated with a risk of morbidity. And we'll come back to that in a moment. So here's where you have a level 4 visit. What you need to do to get here is have either a chronic illness with exacerbation, a new problem that's undiagnosed with uncertain prognosis, or an acute complicated injury, okay? Looking at the risk of treatment, the examples only, so these are not definitive, prescription drug management, a decision regarding minor surgery with identified patient or procedure risk factors, major surgery without risk factors, or treatment significantly limited by social determinants of health. So you need to hit one of these markers to get you into the moderate category. Now, here's a level 5 visit. The number of complexity of problems is a pretty high bar to meet. Severe exacerbation, progression, or side effects of treatment. This basically means you need to consider sending the patient to the hospital, or if they're hospitalized, sending them to the ICU. Okay, this requires a significant elevation in the level of care, an illness that poses a threat to life or bodily function. And I would not be overly casual with how you interpret threat to bodily function. And decision for elective major surgery with identified patient or procedural risk factors. These are procedural risk factors that are specific to the patient's situation, not just a surgery that is of higher risk. Decision regarding emergency major surgery, hospitalization, or decision not to resuscitate. Now, if you're spending a lot of time with patients, you can bill by time. The criteria are different for a new patient or an established patient. To get to a level 4 established patient visit, here you only need to hit a 30-minute bar of time. This is not face-to-face time. This is total time that you're spending on the day of encounter. For a new patient to get to a level 4, it's 45 minutes. Level 5 is an hour. What is included in billing for time? Preparing to see the patient, obtaining or reviewing a separately obtained history, performing your evaluation, counseling or educating the patient, ordering medications or tests, referring with other healthcare professionals when it's not separately reported, documenting clinical information in the record, independently interpreting results of another test, or care coordination when it's not separately reported. This is for the day of service only and includes both face-to-face and non-face-to-face time. So if you're going to bill by time, you need to itemize this in your EMR and make sure it's documented. Otherwise, it's auditable. So the most important thing I can tell you in terms of pearls here is documentation, documentation, documentation. If you can say in your note that the patient is not at his or her treatment goal, you have now established that this is chronic with exacerbation. That gets you into the moderate or level 4 category for that first category. The condition, if left untreated or under treatment, would predictably lead to substantial morbidity or loss of function. That gets you to acute complicated. Again, that gets you into the moderate category. If you're going to document prescription medication management, you have to document that you've reviewed their other medications, potential side effects and interactions. You can't just write a prescription, so you need to document medication management. However, medication management includes either continuing something you've already prescribed, modifying the prescription, or discontinuing a prescription medication. All of those are within the realm of prescription drug management. And most importantly, a decision to defer surgery when it's indicated is a decision regarding surgery. And that also gets you into the moderate category. So I think it's important to have language in your EMR that says the patient is currently indicated for surgery and a candidate. We made a decision to defer surgery for these reasons, and we'll reconsider down the line. A couple modifiers you need to know. A 24 modifier is a unrelated E&M during a global period. So if you are seeing a post-op patient and they say, well, my shoulder's hurting too, even though they just had surgery on their wrist, if you identify, give them a new diagnosis code and actively manage that problems, you can code and bill the E&M visit using that 24 modifier. 25 modifier is a separate E&M on the same day as procedure. This is generally what you're going to use if you perform an injection on the same day as an evaluation. This is getting kicked out a lot of times by third-party payers because they think they can be cheap here. This is not consistent with CMS policy. The E&M that's inclusive in an aspiration or an injection is only the discussion of risks and post-procedure management of the injection. That's in the CPT book. It's also in the NCCI policy manual. So the workup and diagnosis of the problem is a separate and identifiable service from the injection. You need to be able to document a separate and identifiable service. And you need to have consistent language in your documentation that says why it's separate from the E&M work. Again, you want to be conservative with this. So if somebody comes in for a second trigger injection and really nothing else has changed, don't charge an E&M visit with a 25 modifier, just charge the injection. The decision for surgery modifier is only for an E&M visit on the day before or day of surgery. If you're really seeing the patient and indicating for surgery, it's so that E&M visit doesn't get kicked out with the global charge. So documenting procedures, you always want to document that you had informed consent, even if it was just verbal, that you identified and confirmed the site. You want to document skin prep, anesthesia, medications used, needle size, how you localize the anatomic site, good hemostasis, a sterile dressing was applied. You want to document that the patient tolerated the procedure well. If you're using ultrasound, you're going to be billing for it. So you want to use the frequency of the probe and that you had a permanent image retained for documentation. That needs to be in your EMR. You don't just want to take the image. You need to document that you retained the image. Same is true of fluoroscopy. So in summary, you have to determine in your own situation whether to bill directly incident to a physician or split shared. This has repercussions for reimbursement. Good E&M coding is all about documentation, and appropriate use of modifiers will allow appropriate reimbursement when you combine with procedures or global periods from a surgery. Again, effective use of templates and thinking through how you're going to document is what's going to help you avoid audits and clawbacks. Because the people looking at your documentation are not medically trained, you want to use unimpeachable CPT-based language whenever possible. Lazy or cookie cutter documentation, especially when you combine it with high-level codes, is what triggers audits and leads to clawbacks and potential legal liability. And Very important for you guys to understand. With expanded scope of practice, direct billing, and lack of surgeon oversight, having a surgeon co-sign your notes is really no longer going to protect you. Any overcoding, auditing, clawbacks, legal liability is going to be on your shoulders. So documentation is your responsibility. Ignorance is never an excuse, and you cannot hide behind anyone that you're practicing with. So you need to take responsibility and really learn how to do this well. Thank you for your time, and happy to answer any questions.
Thanks, Noah. That was awesome. I had two for you, actually. Everybody else, if you want, put your questions into the chat and we can field them shortly. One, the quote I always got from our coders know about the residents is that it wasn't that a resident was there, but I could put in the note, quote unquote, a qualified resident was not available. So a resident could be scrubbed, but it seems as though it's somewhat vague in what constitutes a quote unquote qualified resident and left to the discretion of the surgeon. Is that your understanding of it as well, or just period, their presence is an automatic, I can't bill for my PA?
Well, most surgical systems are going to automatically document everybody in the room. And so if you're going to say that qualified resident was not available, and yet a resident is scrubbed on the case, that can be audited and kicked back. And so you're going to have to then subsequently explain why that resident wasn't qualified to assist you, even though they were assisting you. And that could get ugly.
Okay, that's helpful. Another one I get is the patient that you schedule for surgery, they want to come back and see either me or my PA and quote unquote talk more about this surgery. And now they want to know, hey, I know we talked about doing your CMC arthroplasty with the FCR, but I read about a tightrope. Should we do that? Should I also consider, having you inject my trigger thumb at the same time or something? But in the end, after this long discussion, the plan's the same. We're moving forward with surgery. Billable, non-billable.
Billable if you document that a potential change in plan was made. It's really unclear there because you're going between CMS and CPT's separate definitions of what begins a global period. I think in most cases that's not going to get kicked out. What happens when things get kicked out is that the discussion is not well documented, and you can't make a good, reasonable argument that this involves significant medical decision making. And if you can talk to an auditor and say, look, we had this 30-minute discussion about potential risks and benefits that was not part of our initial discussion. We went over different options. That's what's unimpeachable, right? And if that's in the medical record, they can't say, oh, because of lazy documentation that, yeah, no, it's a pre-op visit, we're kicking it out.
Perfect. A question that's come up a couple of times is about getting a copy of this. And yes, a copy of this webinar will be available. It'll be on the AAHS website. So for each of you who joined tonight, you'll get a follow-up email from the AAHS staff. And with that will be directions as to how you can re-access this to share with other people in your office. Question for you, Noah. It says from McKenna, so if I'm seeing a new patient for a trigger finger and perform an injection, should I be adding the 25 modifier on these visits so I can bill for the visit itself, the level 3 or level 4, and also the injection?
100%. If it's a new patient, they do not have an identified diagnosis. You need to see the patient, evaluate them, then you make the diagnosis of trigger finger. That's a separately identifiable service from just going over risks of the trigger finger injection and postoperative expectations. So yeah, that's exactly when you should be using the 25 modifier.
Perfect. Another one, Noah, you're the popular one right now. It says, can you give examples of can you give an example of a post-op carpal tunnel who comes in for a repeat trigger finger injection on the opposite side? What code do you use in the modifier?
So that's going to be a unrelated procedure during a global period, which I want to say is 58 modifier. I'd have to double check the modifier. There is a specific modifier for an unrelated procedure during a global period for something else by the same practitioner. And that's a modifier for that. You wouldn't use any unlisted code procedure only. You would use the injection code, which for a trigger finger is, tendon sheath injection 205 or 20511, I believe.
Yeah, a couple people are saying they think it might be a 24, but yeah, so we'll double check whichever one that is, but that there is a separate one.
That's for 24 modifier is going to be for a procedure during another global, but yeah, that's fine.
Okay. And there were some tips, and Don Lalonde had also, just so everybody knows, Don Lalonde was on tonight and had a couple of good pearls in there. Gave a shout out to Ryan for a great talk. Also mentioned the fact that there's evidence you don't need to stop anticoagulants prior to doing in-office Wallant treatment. One of the things he had asked, and it could go to Noah or to Ryan, or any tips on how to get paid for Wallant in-office procedures, that people ask him that all the time. He doesn't practice in the US. So
by the way, it's not a 24 modifier. 24 modifiers for the separate E&M during a global period. The 79 modifier is for an unrelated procedure. In the case of trigger finger injection, where you're not really billing a separate E&M, it's just another injection. That's a 79 modifier for an unrelated procedure during a global, okay? So actually, Glenn and I were talking about this exact issue before the talk began. What you need to do to get paid for Wallant in office for those codes that do not have a defined non-facility reimbursement is to separately contract with your third-party payers or your Medicare administrative contractor. So whereas CMS administers all of Medicare, regionally, there are 11 Medicare administrative contractors that are responsible for all the local and regional coverage determinations. You can negotiate with them for adequate reimbursement that covers all of your facility expense and basically is negotiated somewhere between your just normal physician fee and the facility fee that you get paid for doing the procedure in a surgery center. But there's no way to do that without individually contracting with your payers. You have to show them that it's going to save them money, and hopefully they'll come to the table. And a lot of larger groups have been able to do that. It's a little bit harder for small groups or individual practitioners.
Yeah, I'll just add for us getting it through the commercial payers, usually you just have to have one of them lock on and then the others tend to follow. It started out with our group. If Glenn, tell me if I've got this right. We went to either, I think it was Blue Cross Blue Shield first, because we'd already had some contracts that if we bring cases to a standalone surgery center, we had an increased reimbursement in the physician fee. So we used that and piggyback that and proposed, and I think we had to do like 15% of all trigger fingers done through the group. They had to be done in the office, and if we were able to accomplish that they increase the physician pro fee. So that's how it started, and then once you had that, then you can add another code, and then all of a sudden you're doing all the trigger fingers, 90% of them done, and then the other payers will start to fall behind. I mean, if you think about it, in reality, they save a lot of money by paying a physician more to do it in the office than they do to take it to a surgery center.
Yeah, I think all parties really win with that. You're right. They save a lot of money. And I'll tell you, even before we got the bump in fee to doing them, just doing them there, though, if you just got your same professional fee, oftentimes the efficiency difference of being able to do clearly far more cases in one day in the office than you can in a surgery center can outweigh it almost by itself. So looks like we've got one other question that just floated in. It says this may be getting into the weeds, but it's common in their practice. Patient comes back with recurrent trigger finger after one injection. We discussed the options, A1 pulley release versus a second injection. They decide on a second injection. Should I not bill an E&M code and only the procedure code? And I'll let Noah answer this, but I'll piggyback it because that's what our coders wanted us to do for a while. However, the one thing that frustrated me is now with the Epic portal, a tremendous number of these patients, in fact, the vast majority, I would tell them, hey, if this shot doesn't work, then the next step's going to be surgery. You don't need to come back for a separate office visit. Let's go ahead and review the risks and benefits of the surgery now. And if this shot's ineffective, reach out to me through the patient portal and we'll just set up your procedure. So this, and I'll dictate in my note that this office visit is for the procedure of the injection, but it's also a probable or a potential preoperative visit if it doesn't work to move forward with surgery. So is it only an injection, though, or is that appropriate to also be an office visit because it's a pre-op discussion?
So in my practice, so first of all, the answer is this is all about documentation, right? The difference between this getting kicked out reflexively and being able to make a really good case for this being a separate E&M visit is how well you document that discussion. If you document clearly, the patient comes in with recurrent pain, you evaluate it, it's definitely the trigger finger and not something else, and you discuss different options, say that they're indicated for surgery, they choose the alternative to that. You've really clearly documented an E&M visit. Again, what's encompassed in the E&M for the injection itself is very limited if you look at how CPT defines it. It's not going to stop third-party payers from trying to kick it out. The better case you can make on appeal for this being a separate service, both by having a little rider that this is a separately identifiable service that included evaluation and discussion of treatment options well in excess of what would be included for merely the injection, just having that language there, but also documenting some of that discussion. That's what allows this to be in E&M. So I would do E&M injection 25 modifier.
Super helpful. Well, I think that really rounds us out tonight. We're just over time, but thanks to all of you guys and ladies for staying on. This was a great webinar. Thanks to the faculty for wonderful presentations. And again, thank you to Indo for sponsoring this and for the AHS for making this possible. So thanks to everybody and have a great night.
Thank you.
Good night, everyone.
Good night, everyone.